data, and Susan can talk.
Actually, I'm just about to talk about our CCO metrics.
Yeah.
I don't know that. It's a way to. But great questions. Thanks, everybody. Just wanted to give some talk about our Medicaid reporting. I mentioned already our enrollment demographic dashboards. We have behavioral health dashboards and reporting also available. Our public dashboards include the Drug Addiction Treatment and Recovery Act, or Measure 110 reporting, as well as seclusion and restraint reporting. So those draw on other data sources from those programs. And then we have our CCO quality incentive metrics dashboard and reporting. And so CCOs are held accountable to reporting on performance improvement metrics. There's a subset of the broader metrics that we produce that CCOs are able to, that are incentivized, that CCOs are able to earn financial incentives by meeting metric thresholds for a portion of those metrics. So we report on a broad set of metrics, and then a subset are incentivized for CCOs. The dashboard now includes the demographic breakdown, and it's an interactive dashboard again, so you can search for particular metrics, look at a demographic type that you'd like to identify, look across CCO performance, things like that. So we're pretty excited about that level of transparency, so that communities can look and see how their CCO is doing in supporting their members, for example. In development, we are working on the health-related social needs benefit reporting for the waiver, also a children's health report, which will include the reporting for the early periodic screening, detection, and treatment EPSDT program. So a few things coming up as well.
Can I ask a question?
Yeah.
I remember one of our struggles when we were starting with the CCOs was the crosswalk between HEDIS and meaningful use and all the other definitions and how to measure these things. Like I think about the 2-year mark for pediatric, for vaccines and how challenging that was. I know there were some committees that were forming at that point to try to streamline the definitions. Is there, how has that played out in these reports?
Sure. So, we have the metrics and scoring committee is responsible for the CCO, selecting the CCO incentive metrics, identifying performance benchmarks. We are required now to move to the CMS core set, the adult and child core set measures, which are, I believe, almost entirely HEDIS specified measures. And so some of that has been resolved through that requirement. And then we have some homegrown measures in Oregon for our CCOs, including like social determinants of health screening, and a couple of others. And so, but we'd be happy to, we're not the CCO metrics team. So we'd be happy to have them come and talk to you further, or so exciting work there. Great. So I wanted to just kind of wrap up my section before handing over to Piper on our RealD and SOGI repository and the data available to us. RealD is race, ethnicity, language, and disability. And then SOGI is sexual orientation and gender identity. Oregon has state-specific standards for RealD and SOGI. So these are demographic data that we collect. The purpose of the data are to really disaggregate, to reveal the diversity of people living in Oregon, to avoid sort of having high-level aggregate categories where some, communities that end up being kind of masked in the data. So this is also used to identify health inequities, to adjust how we're operating our programs, and how to best support community members. So these data standards were updated last year. That expanded the race ethnicity categories. The purpose of that is to really look at the populations in Oregon and making sure that our data are collecting to that as disaggregated as we can. And the standards also finalized Oregon's SOGI standards. Our One data collects when someone enrolls in Medicaid through the One system, they're asked the REAL-D and SOGI questions. Those questions are captured on initial enrollment, and we're not able to ask again at re-enrollment. So these data have been collected in the one system since 2022. The data we have for REAL-D and SOGI have some limitations. You know, some members have been in the Oregon Health Plan longer, so weren't able to ask them the updated standards. Also, individuals can skip questions. It's not required that you have to answer these questions to enroll in Medicaid. We have filled in missing data from the one system for Medicaid members with data collected by other parts of OHA. So that's in what we call a REAL-D and SOGI repository. And those are that repository data then is what's used for our reporting in our demographic dashboard or CCO metrics dashboard. So that's a really brief on REAL-D and SOGI. Yeah, go ahead.
So we're coming up on the next 5-year state health assessment. And sounds like your group collects lots of data. That's really important. That actually does give some indications of how healthy are Oregonians. Is any of that data going to be used in the next state health assessment?
That's a good question. The state health assessment is managed by public health, and public health also collects a lot of great data. The data we've been talking about are largely for Oregon Health Plan members, which is a subset of the population. So we do partner with public health, but that's a good question. I'm not sure if they're leveraging Medicaid or data beyond what they already collect in all sorts of days instead of public health.
So I have a question in regards to REAL-D, and
Sure.
currently, Senate Bill 835 is on the floor. And how does that bill tie into the existing REAL-D? Is that based on a geographic region for that population, as opposed to just checking the NAII AN box?
Yeah, so Senate Bill is 835 adds tribal affiliation questions to be collected by Oregon Health Board. And so just for everybody's knowledge. And so the REAL-D and SOGI, the REAL-D questions currently include kind of self-identification of race ethnicity, whereas tribal affiliation will be a separate set of questions related to which tribal entity are you affiliated with, are you a registered member, et cetera. So there'll be some overlap, but it is a separate set of questions.
So that'll identify your nine federally recognized tribes of Oregon, and more tagging them in that social political atmosphere as opposed to race.
That's my understanding. Yeah.
In the REAL-D data set, has there been any additional efforts to try to disaggregate types of disability? I know that the developmental disability community is smaller, and it's very difficult to try to get to social determinants of health outcomes related to people with developmental disabilities, because the REAL-D data doesn't go into that specific level of disability. It's just disability generally. I know that there were some efforts trying to kind of make some assumptions and extrapolations of how to pull out the numbers out of that set that we think might be related to people with developmental disabilities. Has that work continued, or?
Yeah, this is a topic that is continuing to be discussed, particularly as we're looking at our children's health report.
Yep.
And the UPSDT reporting. The REAL-D disability questions, it's a set of, I think it's 7 questions that include kind of functional disabilities. So which does not always capture directly developmental disabilities, for example. We do have data from our Oregon Department of Human Services developmental disability program on program participation. So we're exploring other avenues to kind of fill in those data, but the REAL-D data aren't necessarily meant to identify that specific population. They're meant to, so they're meant more for functional limitations. So yeah, it is a topic that we need to look at, that we are looking into, and we have more to go.
Yeah, definitely. When I've talked with people with developmental disabilities and shown them those questions, they would answer no, especially there's one around, do you like have problems? It's like thinking or remembering or something. And people are like, no, I don't. When they're never going to identify that way.
Yeah,
And so that's always the big challenge with those questions because people they're not going to answer yes.
Yeah.
I have a developmental disability. And just one other quick note, the Office of Developmental and Services obviously does not serve everyone who has a developmental disability in Oregon. So
yeah,
I think it's much less than that.
that's right.
There's many more people than they serve.
Yeah.
All right, thank you.
Thanks.
So I know you guys want to go on, but
Oh,
HR, because of HRSN and social determinants of health, and then the newly passed HRSN, you guys, I imagine within analytics are going to really be working closer now with ODHS, because a lot of that SDOH, HRSN stuff is on that side of the divorce.
That's it. I've never called it a divorce.
Separation, yeah.
Yes, that's absolutely.
What I mean by that
Yeah.
is, they used to be one DHS and OHA used to be one entity, and they got divorced in the early 2010s. They separated the two. And I've always called them the divorce, and we're their children. So who's taking care of which child?
I love that.
You're absolutely right. Working on health-related social needs has caused us to work much more closely with ODHS on Medicaid analytics, on what our kind of traditional Medicaid analytics would be. And one of the health-related social needs eligible populations are individuals involved in child welfare or aging out of child welfare programs, et cetera. So we need to work with, we have to work with ODHS, of course, to get data there. And it's been really exciting to have more of those bridges. They have a research and analytics shop there as well. And so, we coordinate between our agencies.
Do you know who's the head of that?
I do.
I'm ODHS. We can talk after.
Yep. Let's hand it to Piper.
So I'll talk about a couple programs that I managed. So first is the All Payer, All Claims program. So we just heard about specifically Medicaid claims and encounters. All Payer, All Claims is an umbrella data set of commercial Medicaid and Medicare members. So we have insurance claims from the vast majority of Oregon's insured population. So we have medical, pharmacy, and dental claims. We have, a series of information within the claims data, as well as enrollment information and provider information. We have data years from 2012 to 2023. Our complete data has about a 2-year lag. That's especially for the financial data. Utilization data can be a little bit fresher, but to get the full picture of if a claim has been sent back or denied and then resubmitted, that we have about a 2-year lag to be fairly certain that the data is complete. And like I said, it's about 95. We estimate that we have about 95% of the Oregon population represented in one year survey. So, we don't get claims from the VA or ERISA plans, but in Oregon, ERISA plans, those are the ones that just from a Supreme Court case aren't being submitted. So that makes up a fairly small proportion of the Oregon population. It's a larger proportion of other states. So the completeness of other state APCDs, all payer claims data sets, may be less because of that, but luckily in Oregon, it makes up a small percentage. Go to the next slide. And just a little history. So APAC was established in 2009, and here are some of the purposes that APAC is for. So to help with policy decision making, to improve quality and improve affordability of healthcare, to compare cost effectiveness of treatments, and to provide information to consumers and purchasers of healthcare. And then I just wanted to provide a few examples of how APAC is used. So these are not, this is not the full list, but just some really clear examples of how decisions are made using APAC. So the first one is there was a legislative task force in the last couple of years around hospital discharge delays, and our actuarial team used APAC to simulate how benefits for skilled nursing facilities would look in terms of how much we would pay for them if we expanded them to the same amount of days that you get with Medicare. So, and then kind of different amounts of days and how much that would cost. So that's just one way. And then APAC is used in a lot of academic research. One study was to look at PEB and OEB and the hospital payment cap for enrolling out-of-pocket spending and service utilization before and after the policy was implemented, this hospital cap. And then many of our Oregon programs use APAC data. So for the Healthcare Market Oversight Program, or HICMO, they use our data for evaluation of potential mergers and acquisitions. And then our cost growth target program also uses APAC to determine the healthcare cost growth for provider organizations and health plans. And then we also have some dashboards for APAC. One is the hospital payment report that looks at the median prices for procedures within hospitals. And then we also have the primary care spending report that reports on the proportion of spending, total spending that goes towards primary care. And so the next 3 slides are just kind of about the big question of what questions can you answer with claims data. It's not completely cut and dry, but this is just kind of a broad strokes examples of what it can and can't be used for. So this is both around MMIS, like the Medicaid data, and APAC. And just broadly, if someone's interested in a question that's just about Medicaid, like MMIS and Chris's team are the folks to go to for sure. If the question is around comparisons between, commercial costs and utilization and Medicaid costs and utilization, then APAC's a good source of that because we have all payers. So for this first slide, this is about generally descriptive information. So the descriptive information that claims data is very good for is just around service utilization and cost. So how many people had X procedure in which year? How many people were diagnosed with this diagnosis within a medical setting? So, and then how much did certain things cost, both to an average for patients and for the health plan? So those are pretty straightforward uses of claims data. It still takes a lot of time and energy to try to figure out, okay, when you say heart attack, what do you mean? Like, which obviously I'm sure y'all are very familiar with the difficulties of moving from procedure codes or diagnosis codes at the very individual level to like what is meaningful at a clinical level. So there's a lot of work that needs to happen to identify those things, but those are the kind of questions that are very straightforward. For disease prevalence or demand for services, claims data are difficult or unlikely to be able to answer those questions because we only know who's using services. And of course, there's bias in who cannot access services. So it's not a good source of information for unmet need or generally how many people have a disease within a population, just how many people are using services for certain diagnoses.
So my question actually is for Marcus. So I think you can imagine what it is. Are you able to take any of that data and in addition to the studies that you and your team evaluate and present to us, Are you able to take any of this data to be able to tell us about actual outcomes separate from those studies?
I get that one. That's all right. So we actually just got huge data dump from Piper's.
I'm sorry, can you speak up, please?
I'm sorry, we just got a huge data dump from Piper's team. Due to all our benefit update work, I have not even decrypted it yet. We're hopeful we'll be able to access some of that data. That said, it is not peer reviewed. It is ad hoc. So what Marcus and Val and their team does is peer reviewed research that's been through a vetting process. That's what these slides are about, presenting that if it's a simple question, we can do that. The more complex questions were written. I'm often afraid of giving you something that I find out later is misleading you, and I'd rather not do that. So it's a balance, and we're very careful. But you can ask us, and we can tell you whether we can or not, or we can investigate and get back to you.
Is there any way to determine how clean that data is?
How clean it is. Piper, I don't know.
Well, I guess it depends on what question
How
you're asking.
robust and reliable is it?
It's the claims data.
Yes.
Well, yeah, I guess it depends, but that's a quick question everybody wants to.
It's a great
to see. But I think given different populations or different questions that you're asking, our data is different levels of clean. We have a series of validation steps to ensure that we're getting the best data. When we have issues with health plans submitting data that doesn't make sense, we have a lot of steps that are kind of like steps within the process to identify that, and then we go back to them and then we get better data. But there's some reporting issues that just will never go away with claims data. So I would say, like, for the most part, we're very, we have fairly consistent and reliable data, but it's not perfect by any means. And I could answer that question like line by line for each of our variables without taking long. Yeah.
And that's partly why there's a lag, because claims data, there's re-adjudication of claims, that happens. So we have to have a lag so that we let the claims process play out, both for APAC and for the MFISC.
80 days in for the first one. And then that's gonna be.
I just want to follow up with you, Laura. Can you see that this additional information will be helpful?
Yeah, so I would just piggyback on what was said, which is from the evidence side, the things that we want that would help us fall into that unlikely category. And so claims data being the administrative database for the health insurance program, that doesn't have health information that would be helpful to us. And that's just the nature of Medicaid agencies in every state. They're meant to administer the insurance, and claims are the administrative waste product of healthcare. So you can only get so much information from them. Yeah.
Thank you for that.
No,
That's how we think about it from the health.
Yeah.
Voters or anything.
no offense.
Thank you.
I can go to the next slide. So this now moves into more of the analysis and kind of research arena. So this is policy effectiveness is another kind of broad area that claims data can be useful for. However, it's not something that necessarily our OHA teams are equipped to handle. These are more like long-term academic research agendas. And so some of these questions are like, is a certain policy effective in increasing utilization of a certain procedure? And again, these require a time component, being able to see what's happening before and after a policy. It also requires the construction of very careful construction of comparison groups and quasi-experimental methods for creating study design. So this is, again, possible with claims data, however, not something that we can easily whip up for you when a policy is implemented. It's more of It's something that should happen with partnership from academic institutions. And then I'll go to the next slide. So I know that this group is interested in the effectiveness of treatments, and unfortunately, claims data by itself is not a great source of that. For two major reasons. The first is that it lacks the clinical information, such as the intensity of a diagnosis, physician notes, imaging data, lab results. There's also the, not all of the diagnoses within claims are going to match the diagnoses of a clinician. And those might vary based on the type of diagnosis. So there's bias within that as well. And then the other bucket is that we have very few demographic characteristics of patients. So we do have some, like age, we have some race ethnicity data in APAC, although there's a lot of missingness, especially on the commercial side. We have a variable that is for sex, but it's not clear how that is collected. So whether it's sex assigned at birth or somebody's gender identity. And so there's a lot of information that we don't have. So when looking at treatment effectiveness, you're really wanting to have very little confounding and a very clear comparison group for your study group. And that's pretty difficult with claims data, unfortunately. I think claims data can be linked with other data and then used for some of this. But again, that's kind of like a long-term research agenda for like subject matter experts.
Not to beat a dead horse. All of us are using, all clinicians are using electronic record. Is there anything that the state do to encourage the gathering of actual laboratory data and other types of measures from electronic records that would be helpful to be able to really go where we want to go, which is to have more reliable, validated data that will tell us, yes, that's working, no, it's not working?
I think that is largely in the realm of metrics, collecting clinically based metrics. And so that's definitely an area where we have some clinically based metrics. We'd like to get to eventually individual level data, be able to match to other characteristics. But that's within the scope of the metrics and scoring team and our metrics team, and happy to have them talk a little bit more about that. Yeah.
I should say, they have what, a couple of dozen metrics that are collected, is that?
I think there's 3 right now clinically.
So
based.
equims.
Yeah,
So it's very limited to what has been selected, and there's a competitive process for selecting.
I think the CCOs do have better data, like
that's right.
Care Oregon has great data. There's a lot of CCOs who have made these investments. And so their providers can, and they'll have real-time reports that you can pull at will, because we
That's
want
right.
that incentive.
That's
And so we use this to manage our practices.
Yeah.
It exists, it's just not, but yeah, let's get to metric.
That mostly helps with like process of care stuff, are they measuring this, doing this? I think it's harder to use that kind of information to determine whether something works or not.
At the level that we're operating here, I would agree. In a clinical practice, I think you can answer some of those questions internally because you can see it. Because we've been paneled a lot of our patients. And so if you have that model of the medical home or the patient-centered care home model, then a lot of us have been doing that for a while.
Yeah, no, I agree with that. It's meant to be used in that context by the team, I started doing this thing and, what happened, my practice. Yeah.
It would be nice to see us make that connection though, right? From that smaller population to doing it at a state level where we can actually build on those gains from that model.
Yeah, I don't disagree. I don't know that our charge is to improve the quality of care.
Well, but we can match the effectiveness because they have the outcome data. Sorry, I don't know. Work.
You mentioned that APAC has other payers claims data too. And is that a legal like requirement for an insurance company for providing, coverage in Oregon that they then share their data with the state?
Yes, for insurance plans that have over 5,000 covered lives in Oregon, they are required to submit data to APAC, except for the ERISA plans. But again, that's a small portion, so it is required.
So we had a law that passed in Oregon that required that.
Does Washington have it? Is that common? That seems
Like, there's many states that have that, not all pairs, but not all states.
Judy.
because science data is powerful clinically, one of the benefits, say participating in the Medicare's advanced payment models, you get your Medicare claims data and you can see what's happening to your patients. So it's super interesting that the state has claims data for private payers.
Yes, we do have one of the most complete all payer claims data sets in the country.
Wow.
Yeah, and so it is a very powerful source of information.
We can use.
I'm looking at the equity, trying to improve health equity. And so in our decision-making process, we review the best evidence. We take into consideration clinical experience, experts in the field, and public values and preferences. Is there anything from the data that you have available you think that would be really useful to put into that equation for the benefit of improving health equity?
Great question. I guess I would turn to you all about that, if you know your deliberations. And
Yeah.
you can reflect on the demographics of people in Oregon that have a particular diagnosis, for example, or have received a particular service, maybe in the commercial sector or in Medicaid in the past. So those are some things that we could that could provide some context. So that's what comes to my mind.
Yes, we have a health issue or health topic. So just looking at the demographics, do you have all of the different diagnoses available?
So it would be whatever's
ICD
on a service.
Okay,
So
so you have
it's,
the ICD-10s. Yeah. And of all the payers then too, not just Medicaid, most of the payers.
yeah, the data, I mean, they're limited to what comes.
So Medicaid.
Yeah.
Yeah.
So, we don't have people who aren't receiving services, or uninsured. We only have uninsured for hospital, discharge data, which Piper was going to talk about next, but so those are a few things.
And then also with like the healthcare providers, so you have that data too, and like location, distribution. So if you have a health topic, we get the demographics of the Medicaid population. We have you can see the distribution on a map as well, or?
And we can see that generally, in general, for all the Oregon health plan
Yeah.
population, that's in our demographic dashboard. Yep.
Yeah.
So we can look at that, demographics by county.
Yeah. You can see like how many providers would be in
And
that
that's
space.
provider data.
Yeah, so we do have provider data, but that's what is especially messy because sometimes, it's just the entire health plan just assigns one NPI. And so you don't know if it is like the actual place where the person's providing care or if it's like kind of an umbrella identifier. And that is different across payers, unfortunately. So that it's a little bit difficult to discern. And obviously people are providing care in different facilities and we aren't always sure if it's the facility or the actual provider themselves that we're getting. So provider data is probably the most difficult to use within.
Gosh. So that's kind of like the geographic location. Do you have other ideas of what kind of information might be important for decreasing health equity?
I do think geographic location makes sense, and we do have like geographic information about patients. We're obviously very careful with that because it's like highly identifiable.
Yes, when it gets small.
Yeah. But we do have clear patient geographic information either.
I think our CCO performance metrics are also maybe informative, which populations are, where do we see maybe inequities by different populations around particular performance metrics? So that might be, additional input to.
So might that kind of spur maybe which topics we should take on, that kind of?
Or could provide context in a topic that you're already looking into, those sorts of things, yeah.
I'm curious how accessible the APAC data is for people outside the agency. Is that something that you could say, oh, I have a query or something like that and submit it to you all for information? I know you said you had a dashboard, but I can't imagine you have everything available on the dashboard.
Yeah, we do have data requests, a data request process. It is, we are governed by HIPAA, so we can only provide data for to certain entities for certain purposes. One would be like academic research from an academic institution. And so we have a data request process, so folks can come through us. It's a fairly long process because because we're governed by HIPAA, we have to make it very specific to the exact question someone has and the exact data necessary to answer that question. So that takes a lot of negotiation, but yes.
Thank you.
Adrian had a question.
Yeah, it kind of goes along the lines. So it's all payer, all claims, like if it was, do you have all of the identifiers and is that data set linkable with other data sets that are available, or is it all like de-identified information?
Identifiers for, well,
like patient MRN or date of birth or social security number or something that would allow for all payer, all claims to be linked at the patient level to data that's coming from some other database.
So we do have patient identifiers. We don't have social security number. That's part of our statute that we're not allowed to collect that. So we do have like a name and date of birth. That's not information that we ever give out to anyone, obviously, but we do sometimes link patient data ourselves to other data, like certain patient demographics or something, and then provide the file that we create then to other people. And we do have Medicaid identifiers as well, so.
Just, so, I mean, just to think about, as, kind of tangible use case here. So a question that often comes up when we're deliberating is, I mean, we have to make an educated guess. And, I think we feel more comfortable, making an educated guess in favor of coverage if it affects relatively few people. And so what would the process be to say, roughly how many people are affected by this condition? I understand the difference between prevalence and somebody that's Medicare, but so what would the process for that be?
That's something Liz and I can do.
You could do, that's the data dump that you got.
Did this ICD-10 code appear? How many unique individuals service billed?
That's
last year.
That's different than Devin's question of how many people have this condition,
Right.
and the claims is only showing. Like,
Well, who
Right.
Well, yeah,
have-
no, I get the difference between, you can't get the prevalence data, but, I'm sure there's certain conditions for which the private.
Yeah, we're running very late, so why don't we run through the last couple of slides? And
Yeah.
I do want to get to break.
Oh, yeah.
We need to get on the rest of our.
Actually, well, now let's go back 2 slides. So we'll just finish one slide on hospital discharge data. Go ahead.
Yes, and I know that most of the work that you're doing is outside of hospitals, but just as an example, we also have hospital discharge data. It's administrative data as well. It's really good for utilization, not so great for payment because it's not the actual what's billed. And it is great for the fact that it's for all patients who are discharged from hospitals or emergency departments, not just those who have insurance. So we have a larger, kind of more complete population. And we also, I don't think we really have time to go through the dashboard, but we just created a new dashboard that provides that information. And so we'll share it hasn't been published yet, but it will be next week. And so we'll provide that.
For ED utilization.
For
Got a link that's and different stuff from the website.
We can add that.
So we're really excited.
Are they classified as potentially avoidable? Not. And there's ways to classify potentially avoidable hospitalizations from all hospitalizations. Is that part of this?
Not
Just out of curiosity.
specifically, not, we don't get that from hospital discharge, we get that from a different source. However, we do have length of stay and that can kind of be used as a proxy for discharge delay. And so that's one of the ways that we used it. There's also, tabs on diagnosis and demographics, so, yeah.
And patient use, right, overuse.
Obviously, a lot more we could talk about. Thank you so much. Is there anything else, any other sources you didn't get to that you want to?
No, I think just this last one about data requests, real briefly. So your HERC staff are your first point of contact to coordinate data requests. There's a lot of simple things that Jason and team can pull for the HERC. Our staff can respond to ad hoc requests for summarized data for Medicaid in particular, or advise HERC staff around their analysis. We've got some data capacity, or staff capacity and data limitations considerations as we do all of that. But really thinking about HERC, if you have a hypothesis for a data analysis, or you've got a request, staff can work with you on that. Research partners may be needed for more complex requests for research studies, and we can support with data sets, et cetera. So that's it. The next slide is just examples of those types of requests, but I think we've got all of that.
Yeah, so sort of if this stimulated your thinking related to a data question you have, you know how to email us and we will, might say no, but we might say yes. It's our best, as we always do. We want to make sure it's useful. We want to make sure it's resources to fill it out.
Do you partner with any of the graduate programs at OHSU for data and to be able to do research?
We supply data to OHSU for a lot of research and other research partners, but we haven't been partnering like proactively around research projects in a while. So mostly due to staff capacity.
Are they interested in doing research?
Yeah, absolutely.
They do. I think what she's saying is you just don't have the resources to have a rich partnership. It's more we provide the data.
That's right.
They do what they do.
We're more reactive at this point, to their requests. One of the things we're working towards is being more transparent about our analytic scopes. So for example, with health-related social needs, we'll have our analytics plan that we'll publish because this is an area where a lot of researchers are interested. So we want to be clear about what we plan to dig into and where there might be opportunities that for researchers to come in and how to request data for that if they're interested. So, yeah. Great questions and discussion today. Really appreciate it.
Thank you.
Thank you.
All right, let's take a 10-minute break and then we're going to come back and table.
Choose Liz.
Yeah.
We're really doing it.
Yeah, you're the only one.
Which I don't like to do.
Absolutely.
I think the answer.
Hi.
Oh my God.
Easier to do.
Yeah.
You better take it.
Yeah. That's right, that's right. Say your name and where you're from. Yeah. Today. My other side I work on is health IT around health information exchange and stuff. I just want to know, like, I want to know, yeah.
You too.
Yeah, I don't have my information is, or do you have it?
No, I don't have.
Oh, okay. Yes.
Right. Good idea.
Right, well, it's 5 minutes.
Yeah.
I stopped.
Yeah.
Honestly.
Oh gosh, here we go.
It's the name of. The name of the program that you were. Okay, so health.
Considered this, so it was diagnosed.
Yeah, yeah.
Very good.
Yeah.
Yeah.
Well, with Tuesdays? So we are, yeah.
It just felt.
Yeah, I mean, it's best,
Yeah.
you know, I'm not saying. That's
I
it, fluoride,
I realized this.
and then those fluoride varnish. So if you have access, yeah. Fluoride varnish.
Right.
It's always fascinating.
You like, friends?
Yes.
Yeah, I think that's right.
Yes. There is. Right, so we have garnet. Thing.
Right, the fit for both.
Yeah.
No statement.
Like everything.
Sure, you know.
And you go to- But how-
It feels weird.
They have made a picture.
I don't need it right now. They're providing.
So that you
No, and then they recently, it's like, oh, they're. Already running up. It's all dedicated stuff.
Again. Sure, yeah. It's nice to meet you.
It's not just like that.
Aerial is like.
This whole work.
It's very.
Yeah, I years. Give it to me, right? And then diagnosis. It's my job. Yeah. Which I wish. That's it.
It's true, like,
I also.
She's like. Yeah. It's definitely so different. I don't want to be so.
Oh, yeah. Yeah. They both have their very specific resources. I tried not.
I also think.
It's just my calories are higher. So it does, it really.
Yeah.
Yeah, that'd be great.
But I have to do this more.
Well, I think so.
Not moving.
Yeah, right.
I got off my house. So I'm excited. For myself. Oh. The social network. I asked my husband, we have a friend. Okay. Yeah. I don't know what I've heard, but. I don't know. Yeah.
Best, but they're not.
And it's all like, it's not discounting. Like it's all information.
Yeah.
Yeah.
They're supposed to be running us. Getting those for people.
People have to have reason.
Right. Take care.
Yeah, we're like.
Okay, warm.
Here, and this profits this point. So.
Yeah.
Yeah. So now you know, other areas, so. I'm really a lot of. Yeah. So it's. Feel like that's what happens. So. I do that. People want. Yeah. She's.
He's like.
To be like this is floor time, but in this shelter back there. So you don't say that in life.
Oh, yeah. Is that a nice plastic? Yeah. That's. Always, that's what helps about the. Like, I'm not saying. It's just weird. It's just different. Yeah. It's like, that's a way to go. And it's worse.
They all like just talking about.
We're living in the most similar area. I should be universe. I have to say.
That's the last presentation.
Yeah.
Yeah.
I was trying to. You like that?
If you haven't edited it, get it deleted. We're gonna have 4 groups again. So. We could. Hand out, but I want to talk about where the tables are and then everybody can go to the right table.
They're in a way.
So let's just,
Good outcome.
like stand around the edge for a moment here. And then we can start.
Does that make sense?
Copy of the video. Hello.
Where do I get?
If everybody can find a copy of the meeting materials, if you don't have them, we're gonna break it into 4 tables for discussions for, let's say, 15 minutes. And talk about the different sections of the documents. And so I'm gonna go over what those are, and then we'll do that if I can get to the right page here. So let's have down at this corner here, let's have a discussion of the section of the decision standards related to evidence. And oh, and I should say, as you're selecting your table, think about your expertise, what you do know about, but also think about what you know less about, and choose your table based on either one of those.
Okay.
Okay.
right.
Nothing in between.
But consider both of those. Like, sometimes you want to challenge yourself, sometimes you have something you really want to insert into the thing you know about. Either of those are fine. And I also want to welcome Darren Kaufman here. Many of you know him. Yeah, it's our alumni time. If you need a historical perspective on this or HERC, he's here to help with that. And historical perspective for me.
No.
So again, evidence section over here. And then we got guidelines and other payer policies. And the clinician role, which somebody highlighted that we're mixed up a little bit, so we could talk about that right over here.
Thank you.
And then HERC role and process. So this is the first section of that document. I'll be at this table over here. And then here in this section, we'll have the public voice, how we can better incorporate the testimony and the perspective of patients and family members, caregivers, and so forth into our decision process. So pick your table, and if you see one's getting really crowded, pick another one.
Okay, I think I'm gonna do that. Do you want me to?
Yeah, so that your first bag?
I did.
That is.
You just.
Guidelines and clinicians. Process. Like testimony and public voice for perspective. Process, except I'm not.
What does HERC process mean?
It's how we like the districts of our role and what.
You need something.
Walks in. Through sections of the document.
Another payer section.
Guidelines and clinical policy, but other payers as well as just.
Yes.
Yes. Oh, I'm random here.
This is the first part of.
Okay. Favorite book.
What are you knitting? And did you knit the sweater? Yeah. Some.
Amazing.
Oh, I get it. Okay.
From here.
It's the glazed donut, look. 2 layers of bubble bath and 1 of. Oh, hey. Yeah. Glazed donuts. Isn't that fun?
Yes. Wonderful. Yeah, I'm enjoying this one. I'm just gonna do it as like the non.
Yeah, there's a section in here that kind of outlines like.
Clinical guidelines.
Oh, wait, you got it.
Clinical guidelines and work with clinicians, is that the group we're in? I don't. Is that our group? Okay, yes, that's the group we're in. We're in it.
Nice job. Okay, what are we fixing?
Well, what do we wrote out a document.
We developed tennis elbow. I'm typing on a laptop. And
I didn't get a copy.
my knitting.
Right, and so.
That, and also golf. And taking up pickleball, all those things we can't do. Yeah.
So,
It's gross.
Say that it's.
That's true. That's probably better. Probably still is better.
how we do.
Didn't even know what you were reading.
American style knit.
I went to Norway. I was knitting a trip, and like they would have people come in and do like knitting seminars. And one of the guys was like, the beginning valuable. What's the point? And finally, somebody explained to me like, oh, they're all continental here. We're English.
Yeah. My mom taught me how to knit. You know, whatever it is, throwing. But then like within a month, I'm like, I feel like there would be a better way to knit if you just held it and like picked it, sort of. Is that how you do it?
Yeah.
Yeah.
I do both of the color, which I never. It's that like if you do this combination of this, it's easier. You don't get tangled.
I watched yours.
Little, I sat with people. If you do like a little bit and then.
And let it go. I don't understand let it go.
They don't understand it.
I crochet. Do you want me to go? Crochet is like continental knitting. You're just grabbing it and hooking it through, right? That's, yeah, that's what I
have like less than 90 and I work.
If we're editing.
I'm like, let me go.
Craft, but then you have quilting that's not easy to take on the go.
Because it's so boring.
Right.
Well, like I did with that, times to like the color work, I have to look at it. So a lot of people will bring like a sweater and keep doing the like the bottom, it's just sitting around to a meeting. Yeah, we are like guide. Extra interest or.
Yeah.
Any of the above. I'm not even trusting it. It's not the interest. It's bad.
That's bad outcome.
This whole session is about stuff.
Is evidence based, maybe not, like they follow the evidence, but then they also follow the practice, and they get, but then you have like, but then they're also behind.
They actually need.
They had in 365 days, I think that had something like 450 updates.
A little bit.
But they're kind of a wastebasket, right? But they're referenced, but they do incorporate best practices and they say things like many
The loose language.
Could you try to grade the other students?
Exactly.
They're useful, things like the ADA, which becomes very completely astroturf. Like, it's just, it's not talking. Through like patients. And then you have like. And then we're left with, I mean. The cardiac legislation and use evidence, but then they're also heavily wrong or the very waste of time effort.
That's what I was so really racist. You think it's going to me, I was like, why am I so passionate? Right, it's important. I want my needs to go for it.
There's two different parts.
Yeah, I might want to say that exactly.
How do you read that?
High value.
So I was talking to the city monitoring, who would love this information. Like, all these parent pays for this and all these. It's like that. I don't. The evidence is kind of like. Yeah. Medicaire's got a pretty weird low bar. And even their like national security, I've read their evidence reviews and there's no evidence this is like, this thing actually may be harmful for some decision covers it. In kids that have.
When you have the evidence,
Every.
here's these three are the argument. Be factor and all that. But then it
So this process is.
Yeah.
It would work.
Then, you know. Like they're not.
You don't know it.
Value is very, engagement, right? It's evaluatory. So I think it's. So I heard just long, and I want the same way as the ADA. Or if like the nephrology community. Almost always has had external study recommended, why are we, why did we cover here but not there? Oh, that's what experiments. Wax. Do that better.
You're always talking about like there is a hierarchy in a professional society.
Good way to say that.
Evidence based.
That, and you don't have three evidence then. You always be like, it's the same thing.
Yeah, no, if we're
like having a reference document that.
but they have a society.
I mean, that's all the other.
But they don't.
That's is for any.
Like try.
Grading of the society, the group that's moving forward the guidelines. So like the grading can be based on representation, where their funding comes from, right? So how do you know ADA is a mouthpiece of pharma?
What's our job?
What's the evidence that you have?
Well,
Yeah, very good. They're not staff. Staff are also getting paid.
Yeah.
They're just more limited.
It's like you listen to it. Not, it's word of mouth. Reputation. It's some main. Funding.
You can say like,
Aesthetics for a better America, who contributes money to the ADA.
They are careful about these backgrounds. It's not a public, we're dealing with your BBBS process does sort of the same thing as rapid fire. So that the thing, so it's a little more. Yes. In that one.
I have a problem.
So.
Except that, you know, I can't remember the past, like they're different, when I sign up. Yeah.
Right. So it's like, do they clearly report what their benefits are? They clearly state in the guidelines.
But does Medicaid have to cover?
Is there a direct between the evidence?
I mean, we have one side of permanent directions. It's a little different than we're past. Yes, with coverage for medical.
Would be a better.
That was very.
They do have a whole huge evidence section of it, so I guess I could, the NCCN in general does that.
And then conflicts of interest.
Yeah. It's.
When I doubt.
Going back to that tension between. We had a lot of people, a lot of money, and a lot of time, and a lot of. That's the other 200 decisions that are a little bit more.
Regarding benefits.
Yeah.
Right, but
And I try to.
it should be.
And because I trust them, it's a big piece that came out. And so the guideline for how to immunize against, I mean, that, I mean, not a perfect group, but it's a public vetted. Reasonable process. And I mean, there's other theories, but a lot of times I use them mostly just for like their guidelines, because it helps form our guideline words. Oh, all these other payers want to know. We'll do surgery for this policy, but it has to be this. This and this. For those.
Robots.
And like, yes, like these are the factors, but they're not usually important. So, yeah, and then like, the failure. That's amazing.
The evidence we have, rather as data.
But that's what they say.
And the access to the
Also thinking of morality, just avoiding morality is another thing. Yeah.
You know, well, value is.
Like all of those things.
Well, you just try.
Yeah.
Safe reasons of things. How large is large, medium, premium. How large do you expect? It gets us most balanced. How much do you expect that the prices are?
Studies that are off.
Yeah, so there's a framework for make sense. It's very oil house.
Yeah.
So maybe it would help. Processing you were, I think you get some more to this, but something just highlighting the evidence and decision. It's decision making.
All the states are reversed, so they want to do, there's no, we can't use it like this.
I think, you know, I know sometimes the
Before you hear the other.
No, before, after you hear the other, you should only vote.
Do a straw poll. And use that to figure out where they need more discussion.
That's a great idea.
I think you're kind of trying to do that
Can we use it? Can we, okay, who are. Yeah, I think, like that because we use the term diversity, this down and find us.
Like, I, no way, we can.
Like, we're talking about diverse patient population.
I like that.
Today, we can. Is.
Medicare, our umbrella parent, so if they say no, it's actually hard. Never say no, and if they do. Right, so Washington we consider up here because this relationship is similar. We're in problems.
Montana and also.
It's Minnesota.
It's wondering if it's possible. There's almost like a mission level kind of statement that I feel like.
And then I
Have to be aware of.
only because
I feel like there's two
a lot of insurance companies.
general principles that are sometimes aligned and sometimes tension with one another that we.
Use UHC all the time.
Yeah, no, I still.
Like stewardship responsibility.
Right.
And then we have this responsibility to make sure.
Get it all on policy.
Fancy, stuff we influence that.
See, reporter is the database thing.
Here.
Like, is there, what did
So
the,
I feel like it should be plainly stated.
I'm gonna do it
For those things. I think we need to, like, the stewardship part of things has to be
search term?
conveyed.
Function under state statute.
Exactly, yeah.
And that state statute, the government lays out.
Because otherwise it's like you get
Yeah.
somebody saying that like this thing.
And go, and we kind of take. Evidence, we kind of go.
I mean, like, yes, I don't.
What studies
Really clean and
are
better.
in our representative of our population, guess what, you know, which are the ones. Work through that, discuss it, stuck.
We have an obligation to manage the resources.
Yeah, I mean, if I have a bunch. I spell it. Yes. That one. Okay, it's like, everything is like, yeah, the policy reporter. It's a process that I think is. I think it's. In fact, recently.
All these.
So I don't disagree. I mean, I see that as my job as a physician. I'm not sure that's my job, voluntary patient. I mean, it is, there's still steps. There's a lot of things that a lot of other groups do. So typically, I can't remember if these discussions have come up when we were on the commission. We've had topics before where there's a lot of stuff that we can do. Oh, wouldn't it be great if we implemented this program and then you can.
I did get.
You know, all of that. Or do we serve an education? Sometimes our discussions veer into health education. You know, providers should know what the disciplinary care.
Actually, just about.
And we know that we're set up to do that, and you can't do
What do you want?
That's the value.
But I think we have to be cautious.
It really has
That, say, so. That's not our purview.
Does it warrant? Just not gonna put it. We've been making benefit packages. They froze the line. You send out. Yeah. Although the versions that I was getting.
It's just, it's even more like it takes
Financially.
So how we allocate.
That's right.
I mean, that's sort of stuff should be captured in the benefits.
Daily, she gets. Yeah, I think but this doesn't make any sense at all. The shoulder repair, they need to repair.
Yeah, I read about it.
These are.
Yeah.
My perspective is, you don't have your health.
You know.
Livestock.
So I would,
Yeah. But to improve their health.
I've never really, because we've, been constantly.
Right. Yeah, and then every 2 months, just we're constantly evolving and they don't even talk about the, half that stuff that I spent through. It's so is wrong, this is math, that's spelled wrong, like fix this guideline note that has A, B, 2, 3. It's not.
Eric's thinking.
Just be.
Colors to denote.
It is.
And it's like things that were based on very little evidence. Multi-sector, but also I think he was talking about the many situations in which the evidence isn't great.
If it's a positive.
Challenges things.
Operational like that immediately with an exception, which means that the nurses just get the thing that says. Yeah.
This thing is space.
And then it comes up as.
Maybe it's like.
Is that 23 pages? That just gives you the change. How is that going to change?
And how are you gonna draw it?
It's not gonna change, it does, it's all year long. Change it. Yeah.
Right, I mean, one is. There's the expert is to do whatever, I think it's.
I know.
It's,
Right trees. And so like that's worse. So maybe red makes together, maybe it's a checkerboard, but you can just leave it the way it was cracked up. Like if the.
Yeah, exactly.
Have your email.
Yeah.
Right. I always tell everybody, here's the HERC info, here's how you get involved, here's how these. Whole breast reduction thing. Always said you plastic surgeons were up in arms, and I'm like, okay, give me the data.
Yeah.
Show me what you got, I will do, and then they wouldn't answer the phone call. They wouldn't. Yeah. whatever. You're welcome. You guys didn't even show up.
Yeah.
We have that already.
By using the.
I think the staff does a good
My
job
roommate.
capturing that as a rationale.
That's cool.
That's the idea.
Breast cancer.
Communicating that in.
Her, my boss is.
Yeah.
That kind of stuff.
These characteristics.
That's.
Industry.
Yeah, this guy just greater downgrade, like there's really good randomized controlled trial finding this will downgrade our strong recommendation because.
That's been, you know.
Whatever.
But I like Bill's comment, like, the process needs to change. I mean, this, that's like we're talking about. Because the process is gonna change. We either are covering it or not covering it.
You could say.
That's provided are usually cash.
Organizations. That was.
It's really expensive.
Like, I guess, like, that's why it's like. But you can say, yeah, that basis of that would be, yes, really, I mean, cancer and people are saying.
You do.
Sometimes that, you know, like, it's a question.
Patients.
No.
Yeah.
Do we go back?
I like it. So you're not, you don't have to go out and search the entire unit. You know, it's.
Some shit those things really go to CBS.
Right.
Let's read. Here's like this, yeah. Now.
It's like, I was sending patients across the hallway to see one of my workers that specialized more in something else or take doc who was 45 years older than I was. Look at this rash and tell me what it is. You don't get paid. Hey, you know.
So I see a good. Yeah.
Is changing.
I mean, there are ways. Semi-proactive way, topic specific, and that's based on certain clinical trials that go, what the ongoing studies are, and just time to review for what.
For now.
I personally don't think it's set, anything needs to be reviewed every 2 years, because you're gonna know when there's evidence of participate.
Yeah. That's why.
You ever.
So clinicians, so the astrologist will come to you.
Times like. She had to drop the she might see it. And so. But we got it wrong. But if there are other. And it's all charismatic or.
You could get a general surgery consult for appendicitis.
Right.
But you get this or not.
In the ED.
I know, in your office.
You would look at my kid and tell me.
Do we think there's a value to separately denoting when something is expert based or not evidence at all? However we want to. Well, I personally do think there's benefit to doing that, even though the end product is the same. It's because if you look at HERC, I think they assume if there's recognition that it's evidence based.
Should it be in the Russian?
Yeah, it's already there.
It isn't. That's.
It is in the Russian. Right. I just, I was, it says extra finance.
Well, that.
Feels like those to then go up specific cadence of at least. And now 2 years later. There's so many.
When you wonder. Well, think about it. We have people that drive from Eastern Oregon to OHH to get a jillion things done in a day because that's what you do.
Talk to the experts again.
Because the specialty. If we will, you don't have value-based payment like with them, we're just gonna pay them. They're costing. We're just gonna pay them.
And someone was trying to eat your toy dust.
They charge that. We're not gonna pay this.
Yes, I did it. I just.
No, unless that be nothing new, nothing. Yeah. That's nice. I saw one.
We're starting.
Yeah, but I thought you said $16. No, that was province with. Individual, I have got 23 in 1996.
And be able to design from.
Therapy.
Each and something you could set up for 2 years from now, have a AI prompt. What's the new, literature? I mean, it's not perfect, but it's already.
Headline auto alert.
Yeah.
Like venom.
New ones there, and then other one. Yeah, but it's nothing more than
New data supports our. We're, I know, so I see it, it now has.
Okay, look at the next page in paragraph 2. I'm just wondering. Yeah, peer reviewed, start with the top, that's the paragraph, peer reviewed, it's included, blah, 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 blah. We have created a transparent and structured process for understanding the strength and reliability of available science evidence. It takes into account the risk of bias based on design, the applicability of available evidence to OHP, and consistency and precision of study findings and other issues. What are the other issues?
It doesn't.
So early on, surveillance, you know, and, you know,
By the view of news, so it's left, right, center, and it kind of grades the news. You've heard of that creating left, right, center.
Right, that's why it's one of the.
It's not just to pick one, but you need the
in like for
3 to 5.
project, we actually, it's pretty tall.
couple of people.
Yes.
Okay, so did you talk about all those things, Jason, or other issues getting? So we ended up only looking at community, so I like got a lot of directors, sourcing, like find me a community urologist. And then we missed it. Different service, yes, if. So I'm trying to think through, like.
As Kate is saying, it doesn't, yeah, I mean, obviously you want to keep track.
I'd say that, and other issues that may.
In a non-research way. I mean, re-review could literally be. Automated.
I see other issues, like what?
Could literally take less than an hour.
Medical policy that's.
Yeah. So that's way too vague. Excuse. I don't like my food to say and other intermediate.
Wrap it up, think about who's gonna share back in your group, and let's come back together as a large group in about 5 minutes.
Strong, yes, yeah, that's true. But it does say like it is our practice, yes, but doesn't necessarily mean that should be covered. But I'll tell you, the board questions are written directly from us, the board certified physicians, like who are being trained on what to do.
It's like there's.
Like up to date, they draw heavily on up to date. Really well, up to date says. Up to date says a lot. Yeah. No, I'm a second year and I haven't slept in 3 months. Exactly.
If there were. That were
I think our problem right now is we can't get people to do summarize. You can't get them to do the first. There is a desiring faculty members to have this. If we're gonna. And now, yeah.
Creating.
That's right.
Exploring problems. Yeah. Do we need to go to the next page? You can charge us page 4 too.
Well, yeah, corner was about that, means we can focus on that more if you're going that.
People with a. Sit down. Oh, no, if there's somebody else that's at the other section, I'm going to say that. If you imagine it's actually takes I'm not doing what I do really well. I am putting up parameters, man. My husband cannot take you. Yeah, I do. I asked CCOs to find me people. He said it to my boss. Down.
Yeah.
Play keeper, you can tell you're. Like you can't find.
Julie serving.
We found it, but it took 30, it took how many hours?
They have a contract. I think it's, you know, I get all this data from Flames, it's so great, and then they give it to me and I'm like.
I think that either like any
Clinical thing.
Stagger becomes,
I didn't make that up. It was. Medicine president.
Yeah, and I'm sometimes.
So say it again. That's what I tell my boss next time he asks me to look at it again, because I spend so much time.
I said, no, they're like, no, you're right, you're right.
It's right.
Yeah. You know, kind of. And then there's another part of this too. Can experts consider?
So it should be more of a pyramid. An upside down pyramid.
That's like population effective.
Like
Put your strongest, that's what I.
You were saying, that is, you want it to be a literal pyramid reverse with the strong thing on the bottom. Maybe, I'm not sharing.
I'm happy to share it.
Doctor.
Yes.
We're guided.
Something where I'm like. And to add the stewardship.
It's supposed to like go to the United States. I don't know.
I think we were talking about it being scientists. For this one, we are simulation. To the base. Yeah, I think that's the knowledge. I think that distinction of the two terms. I would say.
So
That makes sense. If you just say garbage in, garbage out. Here.
I'll come back into the large group here. You can just turn your chairs around or you can. Something else as the data.
That's really.
Good. Like big factory.
This is.
Thank you for letting me.
That's really. Not on the HERC, but I've staffed it. So I'm at the Center for Evidence-Based Policy.
Working with.
Yeah. I'm just.
Discussion, not to be. I just want to make an executive decision here. Let's start. Everybody, let's start with the group. It's great to hear the robust discussion. I make me glad, feel like we've opened up a lot of questions we won't close today, but wonder if the group that talked about public input and all of that could take a couple minutes to share. And let's do it this way. Let's see, we've got about 50 minutes. So let's maybe share 3 to 5 minutes and then discuss 5 minutes in each group. And then we as staff will take that all back and digest it, maybe some new product based on the feedback you get. So go ahead, public input.
We went all over the place because we were trying to define who is the audience for this document and whether it was for the public or for the commissioners. And we also reflected on when has it gone bad when we've had public comments in the room and commissioners have not felt prepared or the response has not been compassionate in terms of how we address some of these personal stories. And we talked about some of the improvements that have been made with like the preface before the testimony. So we got a little distracted there because we weren't sure like who the audience would be for this. So it's for the commissioners, but it's published publicly. And so then that means that it's for the public because it's out there. And if it's going to guide, but then the other question was, how is it guiding our decision? If it's saying we're incorporating the voices, then what we've described is how we receive input, but not necessarily how it's weighted in our decisions. We've only said it provides information and it goes into the section on values and preferences to ensure the voices are heard and represented. But there's no like, for me, I was looking at the perspective of the person who's contributing their time and effort and managing expectations and wanting to let them know like what to expect before they even participate. So they know like and align it with what is our core value, which is serving these people, serving, not these people, serving the people of Oregon in the Medicaid population, but also looking at how does their lived experience align with the evidence? So is there anything we can give them up front to give them manage some expectations about like, okay, this is the process that you might be contributing to. Here's your public comment. It's going to get evaluated. You'll get an acknowledgement. There's 90 days that we're going to collect. Can we weigh, like, did we get one comment? Did we get 60 comments? Will that change how we address that topic? Will it influence how we prioritize that topic? Which I think it will. So I think putting it out there and being transparent about that and letting them know, here's the first place your voice is heard, will help. But then when the testimony, like looking at the testimony or the lived experience and saying, does it line up with the evidence that we have? Is it supported with the evidence, or does it contradict the evidence? Or is there something individual about that experience that really makes it a one-off? For me, I'm trying to make a decision, right? So if it aligns, it's easy. Those are the things we want to see happen because we know we're doing the right thing. But it's when we have someone who has a really different lived experience that say they really want this procedure done because it's going to change their life. But when we look at it, we're saying, yeah, but 30% of people die when you do that procedure. Like we have to look at the individual, having some kind of weighting that says the individual experience versus the population-based experience. I think to make that transparent to the public so they can see it, we're not just doing that on the backside because of what we know or our training. So I was looking at
being transparent about that.
Yeah, but so, I mean, like, because I think that's the big conflict is the public say, but this is my lived experience. This is evidence. I am evidence. And we say it's anecdotal, it's not elevated. And to me, I don't want to diminish that person's experience. I want to acknowledge it in our meeting time. So we actually did talk about better training for our staff members or our commissioners. But we also, so that we can have an empathetic response in real time, because we all get caught out and it's public and live, and that's. But the other side is, how can we make that more transparent to the public so they understand we appreciate where they're coming from, and like it's going to align with the evidence. It makes contradiction to the evidence. There may be public harms that come from that for a larger group of people, so they can also see the balance between their own experience and how we're trying to make those decisions for the greater good. I mean, that's always the tension between medical care and public health. Comment?
If I understand you correctly, you're not saying the fact that this individual says this one thing works for me, even if the evidence doesn't show that it works for me. You're not saying that we should take that story and turn it into a policy that says cover this. You're saying the evidence suggests that it's really harmful for 30% of the people, and therefore we can't justify a policy, however, or flip it to make it more trauma informed. Sounds like you've had a really potent experience with this and do a better job of acknowledging that story while holding the line for the policy at the level of population-based evidence.
Yes.
Is that what you're saying?
That was very nice.
Yeah.
Okay, so you're gonna start crushing your ball already. Recorded. So Dawn is president of PBS meetings to mediate that.
It's something that's happened to me recently in practice where we're trying to figure out how can we be trauma informed, but still be clear with that doesn't mean that everything gets to happen, that we don't have boundaries, that we don't have clear decisions, but we can still be kind, we can still acknowledge the individual's experience and be compassionate about it. And also like transparent about how their experience is valid at the same time as the population risks and harms that we see. Because that's their world. They're only seeing the harm that was done to them, because that's what we hear about, harm, right? Versus like, what is the risk to everybody else? What about what is here? This is still going to be a group decision versus an individual decision, right? And making that understanding. I think that piece is what we need to be more transparent about.
Setting the expectations.
Yeah, and being upfront about it. And it's not that it wouldn't be considered, because I think there are some compelling cases where it does. So even if there's like multiple branches where, you know, you're saying we use that framework, just like that was up here earlier, that does have lots of loopholes, right? Like it's either harmful, it's not harmful, it is like just some big buckets that are very basic that anyone can understand in terms of like how we're looking at that. Because it could also be cost. I mean, we have to be realistic that we have a fixed amount of money, right? And so there's always going to be the exception and the grievance process. So maybe for those situations that don't fall out clean, it's also an opportunity to redirect and to offer support for them to take things, because we also are going to get things that are not part of our scope, right? And so how can we also do that and be part of the solution and help them along, whatever that path might be, if it's not appropriate to bring, or it's not something that we can do as commissioners.
So
I agree with that, because that statement there is is saying, as a public member, as a member of a citizen of Oregon, right? Oh, I went there and they didn't even listen to me. They didn't even hear what I said, right? We need to acknowledge that we heard what they said. We need to have a recourse of action. Like we make a decision, say, based on evidence, based on all these different criteria. I really am empathetic to your experience based on all of these weights. This is the decision we have come to, and acknowledge that person. And that might not be in real time. That might be through a written response back, but we need to have that engagement with Oregon, right? And
So I'm hearing a real focus here, not as much as I expected actually on how we use the information we get, but on how we respond. Especially when we don't do what a person thinks we should do, that maybe we should think more about the impact that that's having on them and how we manage that relationship. And this person who gets some of those calls, some from the governor's office, some from the, and something to think about.
I also thought when this is presented out, that this section should be on page 1 instead of page 5. It should be at the forefront, because we are here to serve the people of Oregon, and the people of Oregon should be addressed first. And then we have all the evidence based, everything else after that. And then there's going to be things within the document that support this statement, whatever its final statement is, to the people of Oregon and how we interact with them. The answer to that is in everything else. It's our answers to our decision making of that we pointed out. How does HERC determine coverage? How do they take the reasonable benefits outweigh the harms? You know, all of the stuff that the people want to know, right? But they need to be. But this is for the people, you know, and being in public service for over 30 some years, I've been raised, right, to when you're serving people, when you stop referring to them as people, and you start referring to them as a number or as those people,
The public,
right? Then you need to find, it's time for you to go to a different profession.
So can I just add, as the person has to chair the meeting and a full spectrum family practice doc, it becomes a really hard, thin line, because I'm sure you can imagine, I sit there and think, well, this would never have happened in my office, but I can't say that. Neither can any of us. And I think we have to be really careful that we don't interfere with and or damage the relationship that person has with their primary care doctor.
Absolutely. Absolutely.
And that's, I think, a really delicate balance, because, and believe me, there's times where I've thought, wow, you need a new doctor, but I can't say that. Right? You can't say that. And so we are not there to dispense individual medical advice, though we could do a really good job of it. Because we have some really great experts in the room all the time, but that's not our purpose or our job
I don't think that's what I'm asking. I'm asking for the redirection for them to go to the omnibus or some, a place where that structure has been built because it's not within our scope.
Right, so redirecting them to someone who
Saying-
can help them work back to their primary care doctor to understand what's happening.
We
to them.
understand what's happened to you. We're gonna continue to make these decisions today, but it sounds like you could really use some support. Would you be willing to talk to Daphne offline so that we can give you some resources? Because we can't derail the meeting either, right?
Well, as you know, I'm a bit of a timekeeper, so.
Yes, yes.
We have to get through a lot of stuff, so.
Right, but so that's why I think
Yes.
I already do a lot of that.
That's what I thought.
Come through anyway, and switch. But there was, I want to give a little bit of a minority report from this group where we spoke about maybe having staff take a bit of a role in acknowledging the person, not really a script, but things that you as commissioners and subcommittee members might be facing. They're sharing maybe a shocking story and you have time, giving you time to recoup or
Process.
what they're saying. Staff could have things to say to the person that are trauma-informed and comforting and things while you formulate what you want to say.
Like once they're done,
Yeah. Staff come in and
once they're
say,
done,
gives a little bit of time. We appreciate your perspective.
or in between commenters or.
So that was a minority report from this group that some people thought would be helpful.
Just responding to Chris and Michael, what you were saying, if I understood you correctly of, needing to be compassionate, but compassionate doesn't always mean that we agree. We're gonna do what it is that the person is asking.
Correct.
Yeah, that there's okay, yeah, but that for me, I 100% as a staff person, it's a personal pension for me that I feel like because of expectation mismanagement, people are coming to the meeting thinking that if the outcome needs to be coverage or whatever, or else public testimony is being disregarded. So that's a tension for me that I see that how do we build a trust with the public of them understanding that there's we understand and trust the process enough to understand if we don't come to this, if the agreement is the decision is not what validates my testimony, the process is what validates my testimony, I think is what I was meaning to say,
Sure. Yeah, that was very well said. And I think that you're getting at, this whole discussion is getting at why, we put ourselves at risk for this situation by taking on so many topics in the public view, which is, from our Washington, compatriots, like they have a very different way of avoiding this very situation. But I like that letting people know that's the process that validates their concerns.
All right, with that, we need to move on to the next table. If you have more thoughts about this or anything that happened today, you have our email address. There will be a follow-up survey next week. Let's go next to Katie.
Okay.
Our table on her processes.
So we discussed the delineation of her processes, page 1 and maybe page 2, I believe. So we did a little bit of careful reading and wordsmithing, and I think that we recognize that we have already wordsmithed this sentence a lot, or second part of this first sentence about covered by the Oregon Health Plan are safe and proven to work. And we didn't love that. Again, I think we loved before we changed it, and we still didn't love it. And we really feel like we need to add the concept of health value. Have evidence to support health value contribution, something like that. So I think we gave Jason et al. Some ideas of how we keep that, because sometimes there isn't proof, right? A lot of the times we're not talking about proof, we're using evidence, and we also liked the Washington's HTA process where they discussed being evidence informed. And I think that sounds more like what we're doing. We're using evidence to inform our coverage decisions. Not that there's always often like proof. And I think that also validates the role of our experts and our advocacy groups and our individuals who testify, because we're using the evidence to inform the decision as well as we're using their testimony and advocacy groups. So we also, on the second paragraph there, we just kind of felt like some aspect of the stewardship of, public resources isn't there, but that we need to acknowledge that that is a primary role of ours, that we are stewards of a public resource that is limited. And so we wanted that called out a little bit more specifically. Then we get to what is the process for making decisions. We overall felt that this was good. I in particular, but I think, my friends over here kind of agreed that does seem like there are quite a few times we're making decisions with low evidence, not great evidence or conflicted evidence or, low quality studies. But we have, say, a lot of individuals and advocacy groups and experts who seem to have a pretty strong consensus that this, and maybe not particularly bad harm. So we're the HERC, and we're supposed to be using evidence, but we're making these decisions without a lot of evidence based on these other things, and that potentially we could flag or delineate those decisions that we make, those coverage approvals that we make for a certain cadence of re-review. We talk about using AI resources and other things to make it minimally difficult, like not a huge time sink, that would specifically call those back. That could serve as an education to those of us who stick around to see what happens. Like when, okay, this last time HERC made this decision, this coverage guidance in the affirmative, with very little evidence based on enthusiasm. And we just want to make sure that the evidence that comes out thereafter supports that. And if it doesn't, we need to hash it out again. Now there's some evidence, maybe conflicts the decision. And a lot of time, probably we'll have gotten it right and the evidence will support what we decided. And then it can kind of be a consent agenda thumbs up, but have a specific cadence for review for those expert-based, we call them expert-based decisions that really rely on evidence. I think that would make me feel better when we do that, because again, we're using limited public funds we're the stewards for, and there isn't evidence, and we're making these decisions, and we want to make sure that we got it right and follow through. Regarding the page 2, we did talk about this, and I wasn't as attentive, unfortunately, to our conversation here, but we did want to include in the health equity considerations that again, that there are resource considerations. I don't know if you want to add anything to that.
Yeah, I mean, I think this harkens back to an earlier discussion we had about equity that, I mean, I kind of think question 3 is hard to answer as posed. And so reframing it in terms of something concrete like accessibility, which is a concept that, we discussed in an earlier group, are there important anticipated or unanticipated effects of the service on in terms of accessibility, or are there barriers to accessibility we need to consider, whatever, some prompt to kind of think about the access question. And I think we were also wondering if we could add a question on resource considerations, which would be both the cost of the thing and the the size of the population affected by the decision.
Can I ask clarifying questions just to, so I'm taking notes here. So for question 3 on equity, and then wanting to reframe it as barriers to accessibility, how would that impact the ultimate decision or decision-making thinking?
I mean, it's come up, and we've talked even today about specific examples of how we've thought through that. Panda Pans, we were going to require 2 specialty consultations before, getting IVIG or whatever. And then because of access things that came up repeatedly during testimony, we knocked that down to 1. So that was a concrete example of how access considerations played into our decision making.
That was in designing the policy,
right?
Not the decision to cover yes or no.
Well, right. It was in designing the policy, but designing the specific wording around the policy is what you ultimately vote on, yes or no, and so it
Okay.
kind of,
Understood.
it ends up being, yes.
I think we want to be reductionistic and take equity out.
Sure. Yeah, I'm just,
It was an
yeah,
example.
sure.
So I think that's really important because I think we don't want to lose the integrity of what equity means because it's a much broader consideration than just access. So I think that was, the minority report, I just want to say that I don't think it was to do away with the concept of health equity.
Yeah, no, I don't
Understood.
think equity is bad, but I just don't know what it
Define it.
And thank you. And then the second question I had was, you mentioned concept of resources. The question 4 is about the value of the service being equal or better than covered alternatives. How is what you're proposing different than that, or what, is there something missing?
Yeah, it's different because in situations where, especially when there's low evidence, if you
Right.
don't know something really works. I mean, a lot of times we'll say, well, this is a big population that's affected. If it's not a big population, we may take an educated guess and vote to cover something. So I think that's an example of how we consider resources. Or if something is not expensive. You know, I think the threshold for coverage is going to be different than if something was really expensive.
Okay.
I mean, I think we all think about this, but I think we should be transparent about it.
Yeah.
I have a question for Phoebe. You mentioned re-reviewing things that had low evidence or not for coverage. What would you think about re-reviewing things that don't cover because there's no evidence?
Absolutely. And again, this gets to like workload and how much can we cover? So understanding, I think just in general, the cadence of what gets reviewed and re-reviewed, when and how is important. And it sounds like a lot of it is what gets brought to our attention. I feel like there are equity concerns there because, like I said, we know there are certain care communities and areas of care where the providers are very enthusiastic and are going to bring things up to us. And there are probably other areas that aren't. Yep. And so it's just for me, just leaving it to the whims of the clinicians or the patients who speak up, that is a little bit concerning too. So how do you best avoid those equity pitfalls? I don't know, but I do think when we're making decisions that aren't, strongly evidence, if there's some good trials and good evidence and low harms, and we're going to say, yes, we don't have to review that soon. That if somebody brings it to our attention that there's a new, bigger, better trial that says the opposite, sure, but that's unlikely to happen, right? It's when we make these kind of tough calls about things where there's lots of enthusiasm and very little evidence. Sure, either way, I guess. I didn't really think about it if we didn't decide coverage how often we need to follow, but I think it's similar.
I was thinking about those big topics where we have 100 people come to us and say, hey, this is harming me. And then we don't cover it. And I was thinking about having a different, like a more frequent review cadence and like.
I think, right, and in that case, those same 100 people are going to come back to us when that next trial is published. There's probably a low concern that we're going to miss it. But yes, I think we could have a defined cadence for those. And there are probably, technological resources that can help us in terms of, is there a new trial? Is there, just even like trial search, Medline search, PubMed searches, things like that can be automated just to review us, and just make sure we look every 2 years or whatever to see.
To that end, we talked about adding amongst the staff recommendation that we have now, adding a review again in X years.
As the maybe devil's advocate here, I mean, we have time and effort is extraordinarily limited.
Yes.
So
Have to get 2 more.
So we have to find something we can actually do.
Yeah.
That's the balance.
But maybe AI could see the new
Okay.
evidence and say if it's yes or no.
I think unfortunately, we got to keep moving. Lightning round here. Next, clinical guidelines and clinicians.
Yeah,
Which may or may not stay joint. Go ahead.
they're related, but I think they got put together for convenience and we recognize they're separate. I think that a lot of conversation about guidelines are not all created equal and how to put that in meeting materials in a way that we can back up. So this guideline appeared to be based on well-conducted systematic review.
from a trusted source, or this guideline is a mostly expert-based guideline. There was some thought about like, can we have a resource like on our website about like which specialty societies have good guidelines and which don't, but there's a lot of concern that that might not be the best thing to put out there in public.
It's also not consistent between.
Exactly, and it's not consistent within each society, and some society, a society that has really heavily evidence-based guidelines now, in 5 years may change or vice versa, so having, and so I think that would be a good, that will be something that staff will strive to do. I know that the CVP has a lot more resources and really does do more of a dig into the guideline and what's behind it. But I think it's a good goal for staff to try to do a little bit of that, at least for you all to not just say the American Urologic Association recommends this. And even to put in like why. Like I put the AUA guideline in there because they have a good expert-based step therapy to get to this that I thought is reasonable and we could look at or whatever. So that I think I'll noodle around on, but anyway, if anyone has any other ideas on guidelines, great.
I really love that idea. And it kind of goes back to this idea of if we know that a study, an RCT was funded by the manufacturer, right? I mean, so that gives it different credibility. And what I've noticed too is with some of those guidelines, sometimes they don't even have a way of picking their experts. They just, it's not like systematic or
A way of picking.
sometimes they do, and it's very biased, and sometimes it's not. I've seen where it's a panel of experts who've just been asked to do their own research. Like they weren't given how to do the research, what the standards are. Anyway, I love that idea.
Okay, so and if anyone has any other additional thoughts on how you'd like to see that, or like, let me know. And then we talked about experts and the tension between access to like experts who are willing and able to help. And they're either people who are more academic because they have a little more protected time, but they might have a bias just because of the population they see. Versus people who are just really upset with us and they come out of the woodwork and sometimes they're actually wonderful experts. I've had people come to me really angry about something and I'll be like, oh yeah, that is dumb. Let's change that. And then they're totally behind me and they'll help me write a better way of doing it. But we are a small shop, so it's not like we can kind of vet experts, and we kind of take people where we're able to rope them in. And knowing that they're volunteering their time and their expertise, and I have to value that. But we also have, like, for the Benefit Upstate projects, a couple times when we've talked to like academics at the university, it was really obvious to staff that like their patient population is kind of skewed, and maybe we should get a community provider, and how do we reach out? How do we get that to get a different perspective on like the whole population? Tension, no answer, but attention there. And then the third note. Hold on. Oh, and then the other part of ours was other payer policies, and that is a whole minefield. And maybe being a little bit more clear, I am quoting Aetna and Cigna here because they have good wording for a possible guideline. Medicare, being our parent umbrella organization, is always kind of useful, but maybe relying less on other payers other than to summarize like 5 payers appeared to be covering it that I could find and 2 didn't, or something. Any other?
Since we had that presentation from Washington, I'm wondering what you thought about their ad hoc, non-voting clinical member.
I mean, we have that for our coverage guidance process. It's already baked in. For the VBBS, like targeted sort of quick evidence reviews, I get who I can get. And a lot of times it's the person who brought me the problem. And if they're willing to engage and help. In an ideal world, we'd have like a specialty society group that is people who've thrown their hat in that they're willing to help us.
There are state societies that are aligned with the OMA and they're accessible and engaged groups of clinicians in all the state medical societies. And I think we could just access that resource that
We've
exists.
reached out to specialty societies on lots of topics in the past and we haven't found them to be very forthcoming. Like for the ICD-10 review, which was like 10, 15 years ago, we tried to get people from the specialty societies and that was like pulling teeth.
And-
Although not some, yeah, exactly. Better luck with some than others. I feel like it's relationship based, like whoever I can get the CCOs to like get, like I'll send something out to the CCOs, like I really need a community urologist input, and then I'll get a couple people names and phone numbers, or they're people that I know somebody that I've worked with before, and I'll send something like, I need an expert, like you, I'll send you something. I need an expert who does wrist surgery, and you'll say, oh, I talked to 3 people and this person will talk to you.
They're also compensated, and so sometimes it's a different motivation. People aren't in a place to leave their clinical practice.
Yeah.
To come and to do these things. And so I think we've relied on the kindness of people who are, or passion.
Yeah.
To come and to be present to us.
Yeah, that's-
But I do think that makes it difficult to ask somebody and then we're giving them a half day in clinical practice.
Is there a way, I'm just thinking of incentives, because money can't be an incentive, so. Well, can you offer CME or something for?
Oh, that would be awesome.
For serving as an expert?
I know CME.
You don't need to.
Well, like I know when, like you get CME from med, it's a process.
It's, well, that has to be an educational didactic.
It has to be educational. Most boards will allow you to do some undesignated credits that contributes to your certification, but.
Coming up with our, employees who, as individuals, want to give public testimony, same thing. Maybe we could have a form letter or something that gets sent to people. I think reason it's a little easier with academicians to engage is they can put this on FCD is something that is, important for promotion and tenure. I served as an expert resource for the HERC, I think maybe just giving people a nice letter with the state seal and a letter of appreciation that they could just stick in their file.
Like signed by the governor or something?
Feel that it'd be an easy thing to do, and we could just make sure. I also think state society presidents should be helpful in these things.
I would just say this is not a unique problem to Oregon. This is a problem that I struggled with in my state, that every state that we talk to or that I talk to as part of the medical directors network, everyone struggles with this. So I know that's not a super helpful thing to say, but I honestly feel like relative to other states that I've talked with, you have better engagement with specialists here. That's my opinion.
I think because we actually let them come to our public meetings,
Yeah.
and I think they really feel engaged when they do that.
Yeah.
Ones who have the time to leave their practice and have the.
They're also self-selecting, impassioned into academics, impassioned wanting.
People will do it if it's valuable to them. And I feel like, and I think the point about relationships is absolutely key. Nobody knows that this happens. Nobody knows and people know there's a HERC, maybe,
Maybe.
but they don't know. I mean, and I counted, like 5 years ago, I was that person. Yep, I'm like, I'm pissed off about this. And you're like, all right, where are the people? Come talk.
There's far more company people.
And I would have been here 10 years ago if I'd known.
Yeah.
So I think, I like the idea. I think the medical societies, OMA is not the right group, but the medical societies, and then individually, we're all 3 degrees of separation away max. And so if you need somebody, send it out to this, we can find them.
A little more network.
I think more networking. And I think,
Networking, but also this kind of letter idea and you.
Thank you, letters.
Yeah.
Because it kind of, it elevates the brand.
It's not.
Yeah, and reminding people they can submit it for that CME stuff. I submitted for my CME.
Yeah.
And those letters go to public. By non-clinicians as well, I think a follow-up letter with the seal would be really nice to say, you know, we heard you.
That actually is really.
And maybe going into clinics, bring them lunch, and then you'll get them talking.
No more cooking.
Right.
Sparks since it isn't our name. So the evidence table, what did you come up with?
I could do the report out. Yeah. So, the discussion was wide ranging. I would say there were a couple comments about the language in the first part around applicability, just making sure that the studies were representative of OHP members. I made a note, and I can do this. I can get this to you later, Jason. But there was some objection to the use of the phrase "other issues" in one of the paragraphs, so we can clarify that, and just some discussion around the new evidence pyramid and what that was signifying, as well as wanting to give feedback about analyzing clinical guidelines mostly, but sometimes studies, but mostly clinical guidelines around race-based recommendations or recommendations for specific groups based on non-biological factors, and wanting to make sure that that's considered adequately. So I made note of the views. I can give them to you. That's perfectly good. Thank you.
We solved a lot of other really good problems too.
Yeah.
Same.
Good.
Any minority opinions from that table? Anybody have-
Not the evidence base. You said solved. We've had consensus over here.
Short discussion about. Okay.
We believe in evidence.
Stick to the facts.
Well. All right, well, thank you all for a wonderful engaging day. We've got a lot to digest as staff and process and bring back to you all. I'm sure you all will have interesting thoughts on your drives back and there, as I said, there will be a follow-up survey Daphne is going to send out next week. It's pretty brief and multiple choice, but if you have our email addresses.
There's some essay questions too.
Yeah, so please make use of that if you have something to put on the agenda.
Answer.
Yeah, short.
Answer.
And we'll read your long essays too, but. Short is good. But thank you all for a wonderful day.
Actually did that from.
The whole survey that Jessica passed out, get a copy to her. She will collate, they'll have
I give you.
data-based decision making about those items. Yeah, we'll have
On the website.
analysis of the results of that, but as it is, so with that, yeah, Heidi just came on camera. Let's see, Heidi's been listening there.
Oh.
Oh, yeah.
I've been here the entire time. I have 12-page single-spaced notes listening to all of you. So thank you. It's been great. I had no idea what you were saying in the small groups, but.
Yeah, it's hard. She's still getting her feet under her, which you are going to see some amazing work from her at upcoming meetings.
Yeah.
Okay.
This was
All right, with
super
that.
helpful for me. Thank you all.
And that we're going to close the public meeting, so we can log off the Zoom. Thank you all, and we will be